overdose. Let's hit it, guys. Let's see what we got here. We're going to try to recognize when a patient has been poisoned. We're going to have to get information about what they've ingested or inhaled or injected or how it actually entered the body. We're going to look at alcohol abuse and substance abuse. Yep, that's what we're going to do. Poisoning. What population do we see most commonly that are victims of poisoning?
Children.
Children very commonly. What would be our next age group? The elderly. Why do children overdose themselves? Yeah, they're just curious. It's accidental. Why do old people? Yeah, you really have to mix of things with your elderly. They may forgot they've taken those medications, so they take them all over again, which could be serious. You know, if you're taking a blood pressure medication, you already had one, and now you take one in the afternoon, and you don't have a blood pressure. But sometimes you do see where it's deliberate. The other population where we see deliberate poison and overdose is what? Probably teenagers. Yeah, we see it in that age group. Let's see. A poison is any substance that can harm the body. So you can have something that could be perfectly normal that really turns out to be a poison because you took it in too large of a dose. All things are poison. Nothing is without poison. Only the dose permits something not to be poisonous. Paracelsus is how you say that. Okay, common poisons, medications. You know, kind of talked about that with anaphylaxis, but medications is very common. Petroleum products, cosmetics. Don't be eating your cosmetics, girls. Guys, don't be eating their cosmetics. Pesticides, plants, foods. The different ways that a poison can harm the body, it's going to be based on what the poison is, the concentration of the poison, the route of entry, which is going to have a quicker onset if you take a handful of pills or if you get a snake bite. Yeah, why? Yep, it takes a while, but it's going to go through the gastrointestinal system. It's going to be, you know, some reasonable amount of time before that patient is symptomatic, because it doesn't just pass through the lips and then just absorb through your body. So the route of entry is very important. And I mention this because just because you get called to a patient, family says, oh, she took this whole bottle of pills, and you get there and she's fine. There's nothing wrong with her. She goes, there's nothing wrong with me. You do your assessment and everything seems okay. Does that mean she hasn't taken any pills? No. It may mean it just hasn't metabolized yet, and so she's not symptomatic yet. Or it could mean that she really didn't take them. The family just wants to get rid of her or something. I don't know. The patient's age and their general health is important to how a poison is going to affect them. Older patients and your pediatric patients, either end of that spectrum, are going to be more sensitive to an overdose. Patient in bad health, we talked about this the other night. You know, if they've already got cardiac compromise, they already have respiratory problems, and now you load on some toxic poison on top of it, they're going to have a more immediate and more profound effect. Classification of poisons by route of entry. Let's see. These you need to know. You know these. Ingested, that's take it through your mouth. Inhaled, absorbed, injected. We have one more? Can't remember.
No.
I think so. They're all vowels. Y'all got your clickers ready? Example of an injected poison. Y'all miss this. I'm going home. No, I'm not. Not till we're done. Yeah, y'all remember I told y'all that when you're working with kids, always give them a choice that you're okay with both of those. Like I should never say, if y'all don't answer this, I'm going home, because y'all not going to answer it and then we all have to go home. So I say, if y'all don't answer this, we're either going to stay really late tonight or I'm going to give y'all an F. You know, you have to decide. Hey, good job. That was an easy one. Ta-da. Children may be accidental. You know, they're just curious. Adults, it could go either way. Ingested poisons. Here we go. Porch. This is to help you remember. Prescription medication could be over-the-counter medication, recreational medications. Of course, that wouldn't be medications, would it? It's recreational, it's probably drugs. Are they compliant? That means, are you taking more than you're supposed to, or whatever? And H, is it herbal or some kind of supplement? Effects of a poison. If it's topical, you know, if it's on the skin, it may damage the skin or the tissues. It could cause suffocation. If you are inhaling carbon monoxide, it may suffocate you. It could do localized damage or even systemic damage. For instance, a neurotoxin. Does neurotoxin ring a bell for you? Yeah. What kind of snake bite? Coral snake bite. Yeah, that's neurotoxin. How about the spiders? You remember the spider bites? Which one of those is a neurotoxin? Black widow spider bite. Yeah, it's a neurotoxin. Oh, see, I had a thing there. Y'all ready? Da-da-da. Any substance that can harm the body is a what? See if you remember that. Okay. Good job. Okay, ingested poisons. If they've ingested something, what's going to be the time frame we're looking at? Probably an extended time frame where it's not going to be an immediate response. You want to know what the substance was. How are you going to find out what the substance was? You might ask them, look for the container. Remember early on we were talking about those containers and I talked about looking at the label? Think about all the information that's on the label. What's the one key thing you're looking for? A couple key things. The amount. What was dispensed and when? Yeah, was it dispensed yesterday? We're missing 30, Dilaudid tablets or something? Yeah. Patients, whether they're showing signs of poisoning or not, you want to go ahead and transport them. You don't want to be sitting there talking to them and getting a release sign, and all of a sudden their eyes roll back, and their tongue hangs out and they hit the floor. So go ahead and start that transport. When did the exposure occur? I got a call one night, they called at 5 o'clock in the morning, down to some nasty old bar in Gulf Shores, and this lady said, oh, I drank poison. When? About 10 o'clock last night. Really? That was 7 hours ago, 10 o'clock last night? So she wasn't really poisoned. But you need to know when did it occur so you have an idea of when to expect a response. I just took it 5 seconds ago and I realized it was a mistake and I can't get it up. Okay, then we can go and get your stomach pumped. If it was 7 hours ago, call me some other day when something real happened. Okay. How much was ingested? Look at how many pills are missing. That kind of thing. Over how long a time? If they've been taking slowly, somebody's been slipping them some arsenic or something like that over some time frame. So you want to find out when they started taking it. Is it something they're taking on a regular basis? That kind of thing. What interventions have you done? Now, you're not going to ask a patient, what interventions have you taken? What are they going to say? What? So you feel like you've been poisoned. Have you done anything, like try to get rid of it or to fix it? That's what they want to know. Yeah, I drank some milk. I heard somewhere that, you should drink milk after you poison yourself or something. Or I've taken some Ipecac. Really? So what have you done trying to fix it yourself? You also want to know the patient's weight. Why is that important?
See how much, we can send them to their system.
Yeah, a little bitty, skinny, itty-bitty person is going to be react a little bit sooner than somebody that's larger. And you also might take more of the poison if you're larger. You can spread it out more. So for us, that's good. For you little skinny people, it's too bad. Hate it for you. You also want to know what side effects the patient has experienced. That basically is their signs and symptoms. Oh, I've been really nauseated. I've had trouble breathing. I feel like, my throat's closing down. Why is that all blue? What's going on here? Have they had diarrhea? Do they have chemical burns around the mouth? Unusual breath odors. A person that's tried to kill themselves by taking, what do they take? That fluid stuff, carb stuff? Car stuff. What? Antifreeze, that's what I was trying to say. See, the synapses weren't firing. Antifreeze, because I don't take antifreeze usually. But that's going to give you an unusual breath or odor. Now, you may have a person that has poisoned themselves deliberately as a suicide attempt, and then they're going to deny it. So you may look for some of these things to see evidence that they may have been trying to do themselves in. I have a video. I'm going to see if this is going to play right here, okay? Y'all with me here?
Don't do that Internet Explorer. Remember that?
Yeah. I can't remember what
Just, you gotta exit and go if you're gonna edit it and just copy and paste it.
Should I try it first?
Try.
I'm gonna laugh at work.
It's not going to show the movie.
All right, you guys, I got 8 crates.
Stop it! How can I copy this?
You have to
I'm right-clicking it.
You gotta go like you're gonna, hit escape, we'll go back like you're gonna edit the PowerPoint.
Oh, yeah.
There you go.
Okay. So y'all already know where we're going here.
Now, bottom,
You said not Internet Explorer.
the circular thing with the three.
Oh, Google. We'll Google it. Okay. Yeah. Let's do it. Ask me any questions. I'm going to turn the lights off.
All right, you guys, I got 8 crates of Ipecac from Mort, all on my tab. Now, whoever goes the longest without puking gets the last piece of pie in the fridge. Okay, here we go. How's everybody doing?
Good. Good so far.
All right.
Nothing yet.
Cool. You know, I don't know if you guys had any of that pie already, but that is some tasty stuff. That's from the bake sale that Lois was...
Ooh, one down. I know somebody who won't be having any...
I'm starting to feel funny.
Well, I feel fine. I guess I'm gonna...
Oh boy, that means I win. I get to eat.
Oh, God. Why didn't anybody tell me?
Oh, my God, my insides are on fire!
No, please. No more.
Dad, I'm scared.
Get the phone. Call 911.
Lois, get in here!
Okay. I think it's all gone. I think it's... I don't want to... Peter, I need you to hold my ears.
Who wants chowder?
Ipecac. Yeah, that's why we don't give Ipecac anymore. That stuff's awful. Yeah. Oh, you had Ipecac?
Well,
Okay.
when we were younger, when we were sick.
Don't play again. Just turn yourself off.
I took some kind of something like that to make it wait for the rest of them. Yeah, you gotta weigh a certain amount. You get that weight after.
We're already getting here. Okay, so that would be an ingested poison that they had, right? Or did we give that because they ingested a poison? I'm not real sure. It was pretty bad. Now, you ever had food poisoning? Yeah, there's a lot of cases of food poisoning out there that goes unreported. I mean, have you ever come home from one of those restaurants and you're sick and your whole family's sick and you don't report it, you just like get over it? But who knows? Everybody in the whole city may have gotten sick that day and they just don't report it. But improperly handled food or improperly stored food. You ever watch those in the news? They'll say the restaurants this week and their score, they're like scoring in the 70s and you eat there every day. Scary. Okay, signs and symptoms of food poisoning typically are going to be the usual, like we just saw. It's going to be nausea and vomiting, stomach cramps, diarrhea. Sometimes you may even have fever from food poisoning. So don't discount it. If you got a fever, don't think, well, I got a fever, so it's probably not food poisoning. Yeah, it could be. The symptoms may be delayed because it's something that you've ingested, so it may not present itself for an hour or so afterwards. And it could go on for several hours to a day or two before you get really symptomatic from it. often goes unattributed. Activated charcoal is on our list of stuff. Activated charcoal is not an antidote. You know what an antidote is? Antidote is something that reverses the symptoms, reverses the action of that. But we really have very few antidotes. Everybody thinks, oh, we're going to get the antidotes, you know. Well, really, there's not one. There are very few antidotes. So most with food poisoning, and most poisonings in general, you just got to ride it out and hope for the best, fortunately. Oh, did we have a thing? I missed it. I thought there was one more thing. All ready? Which is true regarding symptoms of food poisoning? And I'll just get you on that one. What? Gee whiz, there are only 3 choices. I just got through saying it may be a couple of days. Do you remember me just saying that? Who's sleeping through this one? Okay, activated charcoal. Activated charcoal is one of our things that we carry. Only in Alabama we don't carry it anymore. The way it works is once it gets in the stomach, there's many surfaces to that activated charcoal, and it starts absorbing. It binds to the poison. Once that happens, as it moves through the gastrointestinal system with that big old bound thing, they're going to get really constipated. So they end up giving them some kind of laxative with that. So we don't want to give any of these things on the ambulance because I don't want to be around anybody that's just taking a laxative or that's just taking activated charcoal, because some very seriously bad things happen. They throw up black stuff all over you, and then they poop black stuff all over you. Never a good idea. So activated charcoal is not an antidote. All it does is bind with the poison and keep it from being absorbed by the body. Anytime you're going to have to give activated charcoal, you're going to have to call med control first. Anytime you give activated charcoal, this is even in the hospital environment, they have to have a proper mental status if they can follow your instructions. What's going to happen if they go unconscious while they've got this stuff in their stomach? Yeah, there's a good chance you're going to throw this stuff up. Have you ever seen this stuff? Whether it causes you to vomit, it's going to cause you to vomit. You're going to vomit just thinking about drinking this stuff. So be prepared for vomiting because it's probably going to happen. Okay, about poisoning, make sure that you childproof your home. You know, you think, well, I'm not going to have any little kids in there. Well, sometimes you got some dumb old people too. So I don't mean old people, but make sure you've got all your toxins away. If you've had a few too many beers, you don't want to like run in there and grab up under the sink and drink something bad. So. Sometimes as adults, we don't recognize that we've left some things out that kids that are only 2 feet tall may see and get into. And you think, well, nobody's going to drink that. It smells so bad. Really? Yeah, they do. They don't care what it smells like. You know, they haven't developed that discrimination like you have. Very sensitive. So make sure you put that stuff away and keep it locked up. Sometimes you can have routine household cleaners that look and smell like something really desirable. Gosh, I've got soap in my house that smells like coconut. I have to keep Tim from sucking it down. He loves coconut. That's soap, dear. Don't eat the soap. But you know that lemon cleanser? We got some lemon cleanser. It makes your clothes smell like, you know, a fresh lemon tree or something. Well, it's very enticing to children, and they don't need to be drinking that. So keep that in the back of your mind. And how do they get kids to take their medication? Make it taste like cherries. Make it taste like Kool-Aid. Yeah, so if one's good, several's even better. So you get kids, this is how they poison themselves. That was really good. You know those vitamins we have, those little gummy vitamins? Yeah, we need to eat about a dozen more of those.
I used to do that.
You used to do
I
that?
would eat them with just
Yeah, baby aspirin. Yeah.
and put some.
Yeah, so usually those are probably innocuous, but is that the fire truck or is that like oh, the train? Okay, I should know that. You can't go anywhere within 50 miles without having a train drive right through you. I just want to make sure it wasn't like the tornado sirens.
No, those are very distinct.
Do what?
Those are very distinct.
Yeah.
It is a
Yeah,
tornado.
they're typically they have one.
Here's the deal. If it's a tornado, we're all gonna go hide in the basement in the scariest part of this building. That scares me.
Do our lectures.
Yes, right.
We're gonna wait it out, and then we're gonna come up here and finish.
Not if it's 10 o'clock.
Yeah, uh-huh.
You could just come in here on one of the 4th of July days.
What sense does a small child typically use to identify things? Yeah, how's it look? It looks really good. Smell doesn't deter them. It only interests them. We should be doing a lot more public education than we are. But when you go into people's homes and they got kids, if you see something that is unsafe, you need to say something. Mr. Yuck. Okay, inhaled poisons. Carbon monoxide is the most commonly inhaled poison, and it's associated with fire most commonly. So if you kind of see that on a test, you'll know it's associated with fire, carbon monoxide. Ammonia is also an inhaled poison. Chlorine, I used to work at a swimming pool. Chlorine, you can smell that coming. Agricultural chemicals and pesticides. We have quite a few of those in this area. You know, we're a very large agricultural community here. So there are a lot of pesticides that may be inhaled. What's another way that we can be exposed to pesticides that are bad? Well, yeah, that's
When
never
they spray
good.
your homes.
Yeah, I was thinking about topical, you know, if you get it on your skin.
Or like Monsanto, you really spray it all over the food.
Yeah, that's what you said, things that you eat. Yeah, please don't tell me that. Carbon dioxide can be an inhaled poison. I love this picture, I just couldn't resist it. What does it say? Just when our jobs just when you think your job sucks, this one really stinks. Okay. Anyway, that's pretty funny. I guess those are researchers. Who wants to go into research? Deodorant research? That's an inhaled poison, right? Okay, ready? The most common cause of carbon monoxide poisoning. Quick vehicle exhaust.
I was looking for one.
Okay. Scene safety. Anytime you've got a concern about any type of poison, you need to be concerned about your own personal safety. You know, if it's a gas, you know, if you get a call for one down, like here you can see the garage. You know, you don't want to go storming in there and there's some, you know, gas that's killing off everybody. So make sure that you are prepared with the right equipment. Protective clothing, you know, if it's something that may be topical, something certainly if it's in the air. Call for additional resources. At which point in our checkoff sheets do we call for additional resources? Scene size up. That's right. Okay. Signs of inhaled poisoning, very frequently, it's going to be difficulty breathing. They may have chest pain from that. What do you think could cause the chest pain? Huh? Suppose they've inhaled some carbon monoxide. Carbon monoxide has a much greater affinity for hemoglobin than oxygen does. So instead of having oxygen circulating through the blood, providing healthy oxygen to the cells, you've got carbon monoxide circulating. So if you've got a lack of oxygen to the heart, right, you're going to have chest pain. They may be coughing because if it's irritated the airway passages or the lungs. They may be hoarse if it's irritated the larynx, the vocal cords. They may have headache, confusion, or altered mental status from what? Probably hypoxia, more than likely. They may even seize from that for much of the same reason. Inhaled poisons, you need to know what the substance is if possible. Usually, or very frequently, it's going to be in an industrial setting and they're going to know what that chemical is. Sometimes it's deliberate, most of the times it's accidental. You know when the exposure occurred and over how long a period. You know, have they been locked in this room with no ventilation, breathing whatever it is in there for 5 hours versus, you know, was it 10 minutes ago? It's lightning severely outside. Anybody here afraid of lightning? That's not a poison or overdose. That would be electrical emergency. Have they taken any intervention, you know, trying to fix it? You may have to make a decision about whether you're going to remove the patient from the environment. If he's, you know, in a place and you and it's filled with some toxic chemical in there, you're going to have to decide whether you're going to go in there, whether you're going to wait for backup who's dressed appropriately to go in there, or you're going to be able to move the patient outside. You know, what are you going to be able to do? When they're calling you, you may ask dispatch if the patient's been removed from the environment. You may just open the windows and ventilate the place, and that may do it for you, or you may have to actually move the patient. And of course, what are their signs and symptoms? Treatment, get them to a safe environment. Get them out of that toxic place if possible. Provide them with high flow oxygen. Get them in fresh air first and then get some high flow oxygen. Then you're going to start your exam. You're going to do your signs and symptoms. You're going to get your history. You're going to do your physical exam. Remember the difference here on your trauma patients. What do you do first? Get history or do a physical exam? You're going to do a physical exam on your trauma patient. With your medical patients, we get history first, right? You usually can see your trauma with your patients, but with any of your medical patients, which this is, you need to get history and then your physical exam. Then you get your vital signs, right? Transport any pill bottles, containers, anything that had that poison in it. You want to transport that, but you want to make sure that it is wrapped up, sealed, some way that you're not going to be, exposing everybody in the place. So make sure that it is in some place wrapped up. Continue ongoing assessment as you're transporting. Okay, we're going to look at some specific poisons now. And these are things that if you don't have note cards for these, you probably want to consider them. Carbon monoxide poisoning. Carbon monoxide, you can't smell it, you can't taste it. It's odorless, so you can be breathing in carbon monoxide and not even realize it. Carbon monoxide is a byproduct of combustion. So we see it with, when people try to kill themselves by, getting in the car and closing up all the windows and getting in the garage and stuff like that. You also see it sometimes in people's homes where their furnace is very, is compromised in some way. And so instead of exiting all of those fumes out somewhere, if there's a break in the pipe system, it may be dumping it into the house. So, we used to see it down on the coast during hurricanes. People would bring in their big compressors. Is that what you call them? Compressors? Generators.
Yeah.
They bring their generators in, and they'd be running with gasoline and that kind of stuff. And I don't know what they're thinking about, but it just kind of fills up the house with carbon monoxide, and then they die. And nobody figures out why. But we see it a lot also in wintertime where people are using other types of portable heaters and stuff in their homes. It's never a good idea. Signs and symptoms of carbon monoxide poisoning. One of the first things they're going to note is that they've got a headache, a bad headache. Some of that is due to hypoxia. And one of the things that they report, and I'm not sure why, is that they'll report that it feels like they've got a constricting band around the head. It's not like my headache's here, my headache's here. It feels like they've got a band all the way around the head, and it's just squeezing it. So that's going to be classic carbon monoxide. You'll start seeing dizziness, altered mental status, nausea. They will move on to respiratory distress, cyanosis. Why are they cyanotic? Right, they're very hypoxic. Carbon monoxide has a 200 times greater affinity for the hemoglobin molecule than it does oxygen. That is a huge draw. 200 times greater affinity is huge. So if there's oxygen on the molecule, it's going to knock that oxygen off, and your carbon monoxide is going to get on there. So they're going to be very hypoxic. And it'll really depend on how close they are to the source, and if they've gotten outside and that kind of thing. So with carbon monoxide, very frequently you'll have multiple patients. You'll get a call for somebody that's dizzy, disoriented. You get there and you find out there's 2 dead people in the back room. Whoever's closest to the source. Young children have a higher affinity. They are going to be impacted quicker than an adult does. So you may have children that go down first, and it may look like the flu or something like that. So that's one of the problems. It kind of has some. They're dizzy. They're nauseated. They don't feel good. They start getting altered mental status. They have a headache. It sounds like the flu. And if you got 2 or 3 people in the house with it, well, flu goes around. So this is the kind of thing that can go unnoticed. So you just kind of have to have your little tentacles up and have what is the phrase? A high index of suspicion. Yeah, you got to keep those little wheels running in your brain so you can recognize this. Fire departments really push the carbon monoxide monitors. They have, your little fire, what do you call it, the smoke detector that also come with CO2 monitors. You should have those in your home. It's a combo. They're not that expensive. They're definitely worth it. Fire departments will carry little handheld CO2 monitors where they can go in there and see what's in there. Can you think of any events in our state that have led to increases in deaths from carbon monoxide? Yeah, I just told you that. Those dumb people down the coast. High flow oxygen. The high flow oxygen is going to be the only treatment that you're going to have for these patients. The sooner, the better. As soon as you can get them into some fresh air, you want to put them on high flow oxygen. And then you'll transport them to the emergency department. Sometimes they have to go to the hyperbaric chamber so they can get...
I knew that.
Yeah, I knew
that.
that.
And
Golly. Did you read it in your book?
No, we learned it in our class.
Okay, good. Yeah, so some way that they can force in high concentration of oxygen. It may take a period of time for them to wash out all of that carbon monoxide. So they're going to be on oxygen for quite some time. Smoke inhalation. This is a really big deal. Smoke inhalation goes beyond just inhaling carbon monoxide. What else goes into that? A bunch of chemicals. If you burn one of those nasty old sofas that have all that fake stuff and all that spray and formaldehyde and all that kind of stuff in there, when those things burn, it releases a lot of toxic chemicals. So those substances go way beyond just carbon monoxide. Ammonia, chlorine, cyanide, that kind of stuff. So very nasty. It always surprises me when I come to a house fire or a building fire and I see the fire department out there spraying and they don't have their gear on. They don't have their SCBA on. It's very dangerous. Smoke inhalation, you'll notice it because the patient may have singed, along the line of burns, they may have singed facial hairs, their skin may be very red, they could have blisters, you may see black soot in the sputum, their breath may smell sooty. Those types of things may tip you off that you've got smoke inhalation issues. But when you consider that they're breathing in toxic chemicals, if that's not bad enough, they're superheated toxic chemicals. So if you've ever gone outside on the hottest day of the year and it's really lightning out there, I'm going to turn my back, and the humidity is very high, and they breathe that in, it almost burns your lungs, doesn't it? Well, if the air is superheated and it's like 300 or 400 degrees, outside the toxic chemicals, that heat is going to have a very dramatic and negative impact on your lung tissue, which is very tender. Oh, I probably said all these. Coughing, smoky smell, signs and symptoms of smoke inhalation. Oh, I'm good. Did I go too fast? Y'all have to go back and look those up. If you have a patient whom you suspect's got smoke inhalation, you make sure you move them to a safe area. They need to be on oxygen as soon as possible. You need to monitor their airway. If they breathed in superheated gases, what's going to happen inside their airway? Yeah, it's going to be fried, but think about what a blister is. The skin gets very hot, it blisters, right? It gets really hot and it starts drawing all this fluid there to cool it off, because that's what water does, right? It's going to cool something because we lose body heat through fluid. So you're going to get a lot of edema, a lot of swelling through here. That's part of the cooling process. Part of that, not the whole transaction, but it's a part of it. So their airway may be clear when you get there, but over the course of the time you're with them, it may swell. By the time you get them to the hospital, they can't breathe. It's swollen closed. So you need to be recognizing that can occur and call for some ALS backup if you feel like it's a problem for your patient. There's something, have you guys heard about the detergent suicides? Y'all read, watch TV? Yeah, some of you have. It's a little scary, isn't it? It started over in Japan, and it's moved this way. Now, I haven't heard of anything recently, but probably as soon as a couple of years ago, it was...
Oh, bath salts. Is that bath salts?
No, this is not bath salts.
It says right here the same kinds of bath salts.
They use it in something else to inhale, don't they?
This specifically, they will mix two ingredients, usually some kind of acid and a sulfur product together, And the smallest amount of that becomes toxic so quickly. And what these people do is they'll like put themselves in their car, and they'll roll up all the windows, and then they'll combine these chemicals, and I mean they're dead within a minute or two. But what happens is that doesn't dissipate. Somebody sees the dead guy in the car, and they go over there, one of you guys, you open the door, and that stuff is so toxic it's just killed you. So sometimes if they're nice people that just want to kill themselves, they'll put a little note in the window and say, this is, a suicide here, don't open the door. So they'll get fire department with their.
Have you seen something like that?
I've never seen it. I don't think we're that sophisticated down here. They probably do that in Los Angeles or New York or someplace. But like I said, it started over in Europe, and we did hear about it there quite frequently, and then it's kind of worked its way. But sometimes you'll see that as a way to commit suicide. I think some people are just plain crazy. And they may leave a note. It's a hazmat scene, so you're going to have to get other guys involved. But it's a couple of chemicals that are very, you can buy it, they're over the counter. They put those together. It produces hydrogen sulfide. This was just one that, this was out of Europe somewhere. Excuse me, I think I've got a detergent suicide. Oh, I have a question for you. Y'all ready? Gas produced in detergent suicides. I just told you. Don't get used to this pace. This is not our pace. You get me? I don't know that you learn when we go this fast. Okay. Okay, somebody listened. Others not so much. Hydrogen sulfide. See, it's right there. Hydrogen sulfide. I said it. Okay, cyanide. Next little thing. It's not totally uncommon. Also a byproduct of incomplete combustion. We're going to see this when they burn plastics and other synthetic things, which like is most everything in your house. The thing about cyanide is it doesn't interfere or it doesn't block the hemoglobin molecule like carbon monoxide does. What it does is it affects the cell's ability to use that oxygen. So these patients also are hypoxic, but just the physiology is a little bit different. So they are very hypoxic, and if you smell them, cyanide kind of smells like bitter almonds, which I'm not sure what bitter almonds smells like. You guys may have smelled that. I don't know what that smells like. I like almonds. I didn't know they had any smell. But anyway, that's what they say. Signs and symptoms. The same ones that you would see from carbon monoxide pretty much, except the constricting band on the head. They're hypoxic. So when they're hypoxic, you're going to see signs of hypoxia. Headaches, confusion, agitation, signs of hypoxia. A burning sensation in the mouth, the tissues, the throat, and then of course the smell, whatever that is. If it's a very severe poisoning, coma, they'll become hypotensive. Fluid will build up and accumulate in the lungs. See cardiac dysrhythmias, acidosis. With normal, what is one of the states that we've talked about that causes severe acidosis? See if you can remember. I'll give you a hint. Give you a hint. Let's see. Oh, she said that. God, what was that? Kussmaul, respirations. Who said it? DKA. Diabetic ketoacidosis. Acidosis, does that ring a bell? When the patient gets real acidotic in ketoacidosis, we'll see Kussmaul respiration. So what's one of the ways that we gas off acid? Through the respiratory tract, yeah. So I just want to mention that acidosis. And then shortness of breath you may see as part of this. So you'll see usually some respiratory compromise along with this. Absorbed poisons, okay, it's where you get it on your skin. What do you think if you found some guy, I've seen this, so you respond, he's got chest pain, and you go to do your assessment, and you open up his chest, and he's got 47 nitro patches on him. Would that be absorbed poisons? Yeah. One's good, several must be better. No wonder you don't have any blood pressure. So anyway, absorbed poisons are absorbed through the skin. It may damage the skin if it burns the skin, or it may not. It may just like pass right through. Nitroglycerin, for example, will just pass right through. It doesn't burn the skin. You may have to decontaminate the patient before you provide care. If they've got some type of insecticide all over their bodies, then you're going to have to dust that off and then hose that off before you can provide care. You can't take some contaminated patient into the ER. They frown on that. Absorbed poisons may be immediately life-threatening. With all our medical patients, after we secure ABCs, it's going to be history, physical exam, and vital signs, right? Brush the powder off and then irrigate it. Wash it away. When you're irrigating your patient, you need to irrigate for at least 20 minutes with copious amounts of water. So if it's eyes, you're going to be irrigating the eyes. When you irrigate the eyes, the best way to do that is going to be with a bag of normal saline. You can connect that to a nasal cannula, and you can just like lay them down and open that up, and it'll just irrigate both eyes at once. Now recognize you're going to be pouring water all over the place, so you want to pack towels around them. But as far as other irrigation on the ambulance, we're going to have some bottles of sterile water and saline and things of that sort. You may actually irrigate them on scene, depending on how you need to manage that. You'll transport the containers containing the poison for several reasons. They need to know exactly what it is, and usually on there it's going to give them a pretty good idea about what the chemical was, what the antidote is, or how to manage it or treat it. They'll also call poison control. And I do want to make a comment about poison control. You can call poison control. There's a national poison control line, but we will take our orders from medical control. So what usually happens is you'll call the ER, you'll tell them what you've got. If they have any questions about it, they'll call the poison control center, discuss that with the people there, and then provide you with whatever you need to know. But most especially, they'll be ready for them at the ER. So we don't take orders from poison control. You can call them. I've called them before, just for FYI. But we don't take our orders from them. Y'all ready? Which of these smells like bitter almonds? Let's see what you remember. Okay, severe thunderstorm warning for Lee County until 8 o'clock. Means you can't leave. We definitely can't leave before 8.
It is 8 my time.
Y'all are watching it. I see it. It's getting clear back here where I can see. Is it dark over here?
It's clear. It's pretty dark over here.
Yeah, it's moving south of us. You don't have to worry again. Okay, did y'all get this?
Yeah, that's what I like about living.
Okay. Who picked TSP? Who picked trisodium phosphate? I didn't even say that. Okay, cyanide. Good work. Poison control centers. I already told you this. Follow local protocols for your contact procedures. I'm certain they're going to want you to contact med control and do whatever they say. How does the route of exposure to a poison affect the onset of its effects on the body? Fast or slow, depending on the access, right? So which is going to be the slowest? Ingestion. Gastrointestinal. Yeah. What's going to be the fastest? What's going to be next fastest? Inhalation. Good work. Okay.
Would topical not be slower than ingestion?
Slower than ingestion?
Like burn the skin as far as like problems inside the body.
It's absorbed. Really depends on what it is, but the problem is really nothing is absorbed here. Your first absorption is going to be in the small intestines, so that may take a while before it even empties from the stomach. When it's going here, depending on, if you got somebody that has a leg like this, it's going to take it a little bit longer to go through the leg. But for most of us, if you had a contact here, it's going to move through the skin fairly quickly. Not fast like an injection or an inhalation, but still pretty quickly. Okay, alcohol and substance abuse. We're flipping another page here. This is something that you probably have a lot more familiarity with, I would expect. We are in a college town. So we know a lot of people. We have family members that have these issues, so it's really all around us, and we need to be able to recognize some of these things. Alcohol and drug abuse crosses all socioeconomic lines. It's not just this kind of person or that kind of person. That's drugs, all kinds of alcohol. So you need to be careful about, making snap judgments about people. Alcohol is a potent drug. It affects the central nervous system. Stuff you guys probably already know. It can be addictive. It can be a depressant. You can have alcohol can present with two different issues. It can be an acute issue where, you hear about the fraternity party, some guys jugged, 3/5 of vodka or something, I don't know what they do. And then you have an acute response, or you can have an accumulation where it's chronic, where you have an alcoholic that's ingested large amounts of alcohol over a large period of time. So you're really going to get two different etiologies and two different presentations, generally speaking. Your alcoholic patients, you want to treat them like you would any other patient. There, but by the grace of God, go I, Alcohol abuse can worsen other problems that your patient has. We've talked about that before, that, many of your patients are going to have a lot of problems going on. You put alcohol on top of that, and it can be a really big deal. Oftentimes people that drink alcohol also take drugs and accompany that, and that can be various. There it is. Alcoholic patients, or I shouldn't say alcoholic, patients that are overdose on alcohol, they may be very combative. They may not play well with others. Your drug patients too that have ingested drugs, oftentimes they do that deliberately, and anything that's going to interfere with their enjoyment of their drug is going to make them very difficult. So very frequently you're going to have to get law enforcement involved, and that's okay. That's what they're there for. They like doing it. There are several medical conditions that can look like alcohol involvement. So you need to be able to separate those out as much as you can. Sometimes that's very challenging, but don't close your mind and say, oh, they're drunk. Well, the law books are full of cases where somebody thought they were drunk and they weren't drunk. It was a head injury, it was hypoglycemia, they were having a stroke, all sorts of things can look like that. So probably 80% of the time, if they look like they're drunk, they probably are. But you don't want to get caught in that other 20% where you missed a diagnosis, where you didn't transport a patient because you said, oh, they're drunk, let the cops take care of them. And they had bottomed out with hypoglycemia, you didn't check, and by the time they get them checked in at the jail, they're dead. And who are they going to blame? You didn't do your job. So just be very, very careful about getting blinders on here. Any patient that has an altered mental status, no matter what it's from, they need a full assessment. You need to get as good a history as you can. You need to do a good physical assessment, even if they're drunk. You could have a drunk patient that fell and hit their head. Now they have a bleed in their brain, and you're treating them like they're drunk. 2 hours later they're dead because you didn't recognize that it could have been a traumatic injury associated with alcohol or drugs. You get what I'm saying here? You got to be so careful about that. Alcohol mimics diabetes. What is it about diabetes that can make you think they're inebriated? If they're hypoglycemic, what's the sign? What are the first signs of hypoglycemia? Altered mental status. What's one of the signs of somebody's drunk? Altered mental status. Okay. Epilepsy. Now, if you see somebody having a seizure, you're not going to think they're drunk, right? But you may see somebody when they're postictal after a seizure, and they may look like they're drunk. They're confused, they're listless, they don't know what's going on. Oh, they're drunk. Oh, no, they've been seizing for about 20 minutes. Head injuries can look like alcohol. Head injury, what's one of the first signs of a head injury? Altered mental status. Y'all starting to catch on? High fever. Have you ever had a really, really high fever? Yeah, you get a high fever, for adults, 104, 105. One of the things besides really hot skin you see is what? Altered mental status. How are we doing? Hypoxia? First sign of hypoxia. See where we're going with this? Yeah. So there are a lot of things that can make a patient look like they're intoxicated and they're not. So I'd rather treat them for anything else and hope that I'm wrong than leave somebody, with a serious medical problem. Signs and symptoms of alcohol abuse, they may smell like alcohol, on their breath, but on their clothes, there's just that smell. It's like, whoa, you've been at it way too long. They may be unsteady on their feet. So you may have a stroke patient who's had a stroke, they're unsteady on their feet, and you're thinking they're an alcoholic or something. So, another thing. Slurred, rambling speech. Flushed, complaining of being warm. Alcohol vasodilates you. It's one of the things that it does. It's also a diuretic. So between those two, it's very easy to get dehydrated. Causes nausea and vomiting. You guys ever experience that? Poor coordination, blurred vision. Gee, if this didn't have this and this, what does that look like? Yeah, it looks like stroke to me. Yeah. Confusion, altered mental status. Yeah, sounds like some of our students. Okay, alcohol withdrawal. This is going to be a situation where a patient is an alcoholic. They've been drinking over a long period of their lifetime, and they decide to go cold turkey. I'm going to stop drinking. I've had enough. It's ruined my family. It costs too much money, blah, 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 whatever it is. And so they go cold turkey. They can very quickly move into something called DTs, which is delirium tremens. And this is can be life-threatening. It usually takes about 12 to 24 hours, maybe up to 48 hours before they start becoming symptomatic. So it's not like I haven't had a drink for 6 hours, now I've got the shakes or something. I think I've got the signs and symptoms here. One of the things that makes the DT so serious is they can seize and die from it. They start having hallucinations. These can be scary patients when they're hallucinating. Yeah. And their seizures are just like no seizures that you've seen before. And it can be fatal. Signs and symptoms of alcohol withdrawal. This is as they're starting to go into DTs. They may be confused. They may be restless. The body has just been acclimated to having all that alcohol. It's like it's become dependent on that. You take that alcohol away, and they don't just miraculously get better. Their body has to reacclimate. So you see a lot of confusion, a lot of mental issues there. Can be psychotic. They can appear insane. Other things you'll see besides the hallucinations, so they may start shaking. I mean, uncontrollable shakes. And then, of course, seizures along with that. Profuse sweating. So these are the things that you'll recognize. Sometimes the patient is not able to give you that history. Hopefully there's somebody else there that can. But you should recognize some of these. And then usually they still have signs of alcoholism. Very frequently people that are alcoholics are very thin because they don't eat well. So you may see that they're very slender. You may still smell that smell that you get with alcoholism too. Okay, here's a question for you. I make these way too easy. Shame on me. See, I can't really get much up here. If I write much more than that, it screws up the whole frame. So, good work. Patient care for alcohol abuse. They very frequently vomit. So, how was our patient care with vomit? Nay, nay, stay away. From vomit, stay away. Do y'all remember that one? Probably not. So be ready for vomiting. If a patient's going to vomit, what's going to be your BSI? Gloves. I'm having my glasses on for sure. I like a mask, but I don't usually open my mouth when people are vomiting, but I have a hard time with keeping my eyes closed. Keep your suction ready. You're going to be suctioning these guys. Stay alert for any airway compromise. If they vomit and they aspirate, they've got an altered mental status. They may just swill that stuff right down through the airway. Never a good idea. Watch their vital signs. You're going to continue your reassessment constantly. Try to get as much history as you can. As I said, you're probably not going to be able to get it from the patient. You may get it from family members or bystanders. And then recognize that they may seize on you and be prepared for that. Does seizure kill people? Yeah, not typically. In this case, though, they may go into status epilepticus. You remember what that is? Prolonged seizure without a period of intervening consciousness. Excuse me. Okay, we're switching over to substance abuse. We're going too fast. What, y'all need a break? I don't know how much more we have here. This is the 100 slide, so yeah, it goes on. We'll do a few more, then we'll take a break, okay? Do what?
I thought you said we were at 100 dollars.
No way, yeah. We've got to get to 100.
What are we on?
I don't know. It's coming up 0.
61.
We're on 61?
That's what I got.
Oh, you print them all out?
No, I
Just can count.
I do them all, or number them.
No way.
Yeah.
That's just a
I'm
little,
serious.
it's a little anal retentive. We probably need to talk. Okay, substance abuse. I could probably recommend some substances for you, okay?
No, I'm good.
Okay. Substance abuse. Any chemical substance taken for other than therapeutic reasons. So that would make them recreational substances, right? So, like in California, marijuana is a therapeutic medication. In Alabama, it's recreational all the way. You know what I mean? You'll go to jail. This includes illicit drugs, of course, prescription drugs, over-the-counter drugs, just about anything else out there that you can encounter. You abuse it. Okay, we got several classifications. These are very generic. We're not going to go into anything very deeply. The point here is you need to recognize what's going to be a stimulant to your patient and then what's going to be a depressant so you can treat them appropriately and recognize them. Uppers, these are things that are going to stimulate the central nervous system. Cocaine, for example, amphetamines, and they can enter the body in several different ways. They can snort it, inject it, smoke it, chew it, brownies, what?
Cocaine, can't we put on the skin and absorb through that?
Ask your buddies. I don't know. I don't know. Is that the way you
I've
do
heard
yours?
it can be.
Yeah.
But I don't believe it.
Really?
Like acid and stuff
I wonder
like
if you
that.
mix it with some type of topical agent, you know. I don't know.
Typically, the people who do a lot of stuff, they start off snorting it and then they end up either injecting or smoking it.
They get very creative, I guess.
Well, it's just you don't get high from snorting it anymore.
Kind of become resistant to it. Okay, signs and symptoms of a patient that have taken some kind of a stimulant. This is the eyeball I was talking about last night, you know, when you get that huge dilation. You'll see these patients, you know, you walk in there and they have that, they call it wild-eyed look for a reason because all you see are pupils. And you see that on a patient. I'm kind of backing out. I'm making sure I got all my stuff ready because this looks like somebody I may be running from in a minute. They're very excitable. They're very anxious, very restless. When you take their vital signs, this is a sign of sympathetic overdose, basically. They're very tachycardic. Their respiratory rate is high. They are getting after it. They're going to be sweaty, you know, because they're creating a lot of body heat because of this. I think I mentioned to you methamphetamine, cocaine, both of those can heat your body up really high. You can have an overdose where the patient actually gets a body temperature of 108 degrees and it just fries the brain. You know, it's just such a heavy and strong stimulant. Patient becomes hyperthermic. It's kind of weird. Sometimes they will tell you they've been awake for days. You know, they're just wide open for a long period of time here. Creepy. Central nervous system stimulants, uppers. So the pupil is what you're going to notice. They're going to be freaking out. PCP, cocaine, amphetamines, methamphetamines. I can't remember what's on my YouTube thing. I don't think it's anything really exciting. Y'all watch it online, okay? By the time I shut this whole thing, well, I want to know what it is now. So I have to end the show. Oh, I thought you wanted to see it.
Sure.
Jordan, you're a
counting.
Well, what did it say?
71.
Oh, well, it's
Methamphetamine addiction is spreading throughout America, and these are the faces of meth Mal.
I'm Brendan. I'm 37. I use meth, and this is my smile.
Look what meth has did to my mouth.
Meth use can destroy your teeth, American Dental Association President-elect Kathleen Roth explains.
Methamphetamine causes dry mouth. That, combined with poor oral hygiene and a diet that's not what it should be, causes tooth decay and chipping of teeth. In no time, you've destroyed a beautiful smile.
This condition is known as meth Mal. Black decay, rotting teeth, extreme sensitivity, and teeth that literally break off, teeth leveled at the gum line, all symptoms of meth Mal. All problems Karen Brown endures as a former meth user.
It's very uncomfortable. You know, I can't eat like anything I want to eat because the teeth are broken off, and sensitivity and abscessing from the meth. I mean, there are times when I would do a little bit of meth and my jaws would just start swelling up from the infection.
Meth dries the mouth, reducing saliva around the teeth. Users tend to grind and clench their teeth. Often there is no hope for treating meth-damaged teeth, and teeth must be extracted. Dr. Keith Collins of the Partnership for a Drug-Free America further explains.
The worst thing that you see is an infection that's really out of control, and people can even be infected badly enough to require hospitalization. So aside from that, the worst things that happen with dental problems are people can lose all of their teeth.
Still don't think meth is dangerous to your oral health? Think again, says former meth addict Paul Murphy.
It destroys your teeth. It makes you think you're something that you're not. It's a horrible drug. Meth is a horrible drug.
This is Rainey Mitchell.
Were y'all familiar with the whole meth mouth thing? You'll see a lot of that. Probably shouldn't tell this. I have a niece that looks like that. She lives in Miami, and she's a meth head, and her teeth are so bad. But her mother says it's because she drinks Coca-Colas and smokes too many cigarettes. Not that mouth. You'll see that mouth, and accompanied with that, they usually have really bad skin. You know, they're so unhealthy. The skin is horrible. They usually get very thin and drawn, and then the teeth are just as scary as can be. So you'll see a lot of these patients. I mean, these will be your patients. Yeah, creep you out. Okay, I think we're talking about these. PCP is a hallucinogenic. Patients that are on these, they will present with extreme agitation. They are freaked out. They are just, you can tell they're high on stuff. And they can be super strong, and they can be super aggressive. So you have to factor that into how you're going to manage a patient. Extreme agitation, they may be unresponsive to pain. I have seen these people where they have shot them with a taser gun, and they keep on coming. They just keep on coming, going, you're having about 4,000 volts of electricity going through your body, and you just keep coming. It's pretty weird. You know, these are the people they've been shot and stabbed. Doesn't matter. They just keep on coming until all their blood flows out. Which, when all their blood flows out, what do we call that? The E word? The sanguination. Okay, just checking. Heart attack is not uncommon at all. They become so tachycardic that they go into SVT. And then you have to treat them like you do a cardiac patient. Because they have a heart attack from it. It's pretty creepy. Aortic dissection. That heart is going so much and so fast it can cause an aortic dissection. Where did we say most of your aortic dissections occur? The chest. The dissections occur in the chest. The aortic aneurysms occur typically in the abdomen. They'll have a severe headache. Why? Their blood pressure's out the roof, maybe? Yeah. When, with this level of excitability, with that sympathetic response, what happens to the vascular system? Vasoconstricts, that's right. So that's where they get that headache from. Okay, the opposite is going to be downers. anything that is a central nervous system depressant. What is the main problem we're going to have with these patients if it's a central nervous system depressant? What? Yeah, it goes right back to respiratory. If they get too much central nervous depressant, something on board, they're going to stop breathing. So that's what you're worried about here mostly. Barbiturates, roofies, rofinol, GHB, these are all things you've heard of. All these are depressants. Patient will present very sluggish, poorly coordinated, don't walk very well. Their vital signs are going to be depressed. You know, this is your parasympathetic response. The blood pressure tends to go down. The heart rate goes down. The respiratory rate goes down. What happens to the mental status? As you become hypoxic, it's going to go down too, right? Narcotics. These are going to have the same types of responses that you're going to have from a downer. It basically is a downer. People take it to help them sleep, to help calm them down. It's a pain reliever. The ones we see most commonly with problems, heroin has become, it's come back full circle. You know, in the olden days, not so long ago, you know, people didn't use it. They used it and then they quit using it because they found other drugs. Well, it's back. Codeine, morphine, oxycodone, all of those you'll see. And a lot of these are, some you can actually purchase, you know, as part of a prescription. Others are like heroin. There's no real therapeutic use for that. Signs and symptoms that your patient's using narcotics. You can't see this very well, but we've got pinpoint pupils here. They're very small. This is relaxing your patient. It's a parasympathetic response. So the pupils relax. They're going to go small like that. So which are the ones where you have the big pupils? The stimulants. So the small ones are very frequently narcotics of some sort. The patient will be very sleepy, kind of lethargic. The pupils are very small. The skin will be cool. They have respiratory depression. That's your biggest problem here, that their respiratory rate slows down to the point that they stop breathing. They'll eventually go into a coma and die. You know, they just kind of basically fall asleep. Hallucinogens, these are always fun. There's no reason for any of these. This is not a prescription that you get for PCP or anything, or ecstasy. But it puts the patient in a state of extreme excitement, but it also distorts their perception. These are the people that feel like things are crawling on them. You know, they see things, and, you know, I mean, they're running across the lawn naked because they think, you know, somebody's chasing them or other. And these patients on hallucinogenics are pretty weird. Signs and symptoms: altered mental status, changes in thought pattern. We're not talking about people that are obtunded. We're talking about people that they see things that you don't see. They have altered ability to take in information. They just see weird things. They're usually going to be tachycardic. Pupils are going to be dilated again. Flushed face. They see and hear things. And if you have a patient that reports things are crawling on them, you can't get a fly swatter and beat them down. Okay? You can't start slapping them. You know, you've got bugs on you. You can't do that. But they think they see those. So you just kind of say, yeah, I understand you see that. I don't see it, but I understand that you do, and don't slap them around. Okay. Volatile chemicals. This is huffing. We saw that picture that came up a minute ago. When he pulls this bag away, he's probably going to have colored stuff here from paint. This can rapidly kill you too. They're inhaling the vapors. This provides a high or a rush, but it also will be a central nervous system depressant. They may have an initial high, and then they become very depressed. All their vital signs become depressed. Usually dazed and disoriented. This rush or this high doesn't last very long. It's very short-lived, and then they become very obtunded. But you'll recognize them because their mucous membranes are usually swollen. You know, it may appear leaky. Their nose and mouth may be red, or it may have some coloration on it. They may say that they have a numb or tingling feeling inside their head. You may see some cardiac dysrhythmias. It's never good. You may see residue on their face if it's paint or some kind of chemical, or it may be around them somewhere. Substance abuse in general, it can be difficult to assess depending on what they've taken. But you want to assess their level of consciousness, their mental status. Sometimes they combine several drugs at once. They may be taking some narcotic and then they're going to come and puff some volatile chemicals or something. They may be very combative. They may be very difficult and uncooperative. You want to do an assessment. They won't have any part of it. Watch out for any contaminated needles. They may be in their pockets. They don't care if they get stuck again. They've already done that. Maybe in the back of seats and sofas and things of that sort. So you've got to be very aware if you suspect a substance abuse issue. Patients may have airway problems, so particularly on any downers, any of your narcotics, you're looking at potential airway problems. And usually if you can provide ventilatory support for these patients until the chemical wears off, they'll be fine. The problem is if they become so respiratory depressed that they die before anybody helps them, that's not ever good. So you may have to assist respirations. You'll treat them for shock as you would any patient. Do a good physical exam. Look for any evidence of any needle marks. This is difficult to see, but some long-term drug injectors, they're going to have streaks along these veins. Last night we were looking at the IV arms. Remember, did you notice those things have been stuck a million times? So you can see those veins on that plastic arm, just like you can see the vascular system here. They always stick in a vein, and so it leaves these track marks. Every time you stick a needle through your skin and then into a vessel like that, it's going to form scar tissue. So most people, if you get an IV, it might happen 5 times in your lifetime or something. But these people are constantly poking their vessels, and it causes scar tissue, and it starts to pump up. It'll eventually scars on the outside, but it makes it very difficult if you ever do have to get an IV because they've got so much scar tissue inside there. Okay, patients that are on some type of chemical substance, you need to go ahead and transport them. You may have to get law enforcement involved, and that's okay. You may have to restrain these patients. And that was one thing, I don't know if I mentioned to you early on, that make sure you know where your restraints are on your ambulance. Because these patients come out of the blue and you need to restrain somebody. Make sure you know where they are and what they are. Did I mention posing restraints to you? I had a paramedic student work with me years ago. He was doing his rotations, and out of the blue, we ended up with this patient. He was diabetic, he was hypoglycemic, and he was off the wall. And I yelled at my student, I said, go and get me the posies. Okay, and off he runs. And I'm waiting because I needed those daggone restraints. But that was what we called them. That was the manufacturer was posing. And he comes, after a while he doesn't come back, so I sent somebody looking for him. And he's just tearing apart that ambulance. He didn't know what the heck they were. So make sure you know what these things are and where they are in case you have to get your hands on them in a hurry to restrain a patient. Now you're supposed to get med control approval before you restrain a patient. That's not always possible. You may have to restrain the patient and then make that call as soon as you reasonably can and say, I've had this patient, we've had to restrain them. We see this frequently with patients that are on some type of substance, some type of stimulant, and also with your hypoglycemic patients. They become so aggressive and they're so strong. It may take a number of people to hold them down. So you may have to restrain them until you can manage them. Oh, here's a question. Was there a star there? Yes. Hello. Hey, wake up, guys. Let's see if you remember this. Some did. Okay, these are hallucinogenics. Think about hallucination, distorted perception. Narcotics, what do narcotics do to you? They make you stop breathing. So anything that says intensive state of excitement does not go with narcotics, okay? Look where we are. Da, 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 da. Always do your primary assessment. regardless. This whole chapter is about poisoning and overdoses, substance abuse. So oftentimes you're not going to know what your patient's on, but you need to do a good ABC, because the bottom line, it doesn't matter what they're on, we're going to manage what? Their ABCs, airway, breathing, and circulation. Even if we never figure out what they're on, the bottom line is ABC. So make sure you've got that managed. Get as much history as you possibly can. Do a good physical exam. Get your vital signs. If you can, find out what the poison was and what the entry route into the body. You want to know how much was taken. If it was a poison, how much did they take? When did they take it? Over what period of time? Go ahead and get their weight. Most treatments for poisoning is going to be weight-based, so we want to know how much they weigh. And that's important because the heavier you are, the slower absorption you're going to have, regardless of how it entered the body, typically speaking. Consult med control before you give it any activated charcoal, or don't give them any milk or anything like that. Pardon me. If they've inhaled a poison, it's going to be oxygen. That's what you're going to do. If they may have inhaled a powder, if it's on their skin and you stir it up, then they may inhale that. So you want to be very careful when you're brushing it off, and then you're going to irrigate it, right, to dilute it. You want to transport all the evidence of the overdose with you, but seal it. Reassess your patient. Document everything, the poisoning, the route, what you did. Safety is your number one concern. Now, this chapter specifically wasn't about suicides, but anybody that would try to kill themselves, they don't think twice about trying to kill you. They obviously don't care. So, safety, your personal safety is always going to be at the top of the list. Let's see. Look for scene clues. Oftentimes, that's going to tell you what's going on. If there's 500 beer cans in there, we might have some alcohol on board here. The effects of abuse may vary, so make sure you are assessing your patient specifically, looking for uppers or downers, stimulants, depressants, that kind of thing. Okay, I thought I had one more thing there. Ready? Narcotics will cause let's see who's going to pick the mystery word. Pretty good. Nobody picked the mystery word because you didn't know what it was? I'm going to tell you. Anisocoria. Anisocoria means unequal pupils. So you got a head injury patient, they may have anisocoria, or one's going to be larger than the other one. I mean, considerably. So dilated pupils. Who gets dilated pupils? What drugs? Stimulants. Constricted pupils. Narcotics. Depressants. Anisocoria. Head injury, stroke, that kind of thing. Ta-da! Okay, a farmer calls 911 because one of his farm hands has tried to clean up spilled pesticide powder with his hands. Oh, I'll fix that. On arrival, you find the patient insists he's brushed all the powder off. He feels fine and doesn't need to go to the hospital. As he talks, he continues to make brushing motions at his jeans, on which you can see the marks of a powdery residue. How do you manage this?
Ask him if you can take off his pants, but that's probably what's going to cause that sensation in his legs.
Yeah, you probably have to take those pants off. Here, get over here behind this curtain. You want to know what the pesticide is. You want to know when he was exposed and what they've done for it. Probably nothing. Ooh, organophosphates. I don't think this is in your book. Did y'all read the book? Was organophosphates in there? See, this is something I had to add. Organophosphate poisoning, we're going to see this with insecticides. So in a farming community like this, we're going to see a number of organophosphate poisonings every year. Malathion is one, sarin gas, all these are organophosphates. Organophosphates are nerve agents. So you're going to, can't remember what all I have on here about these nerve agents, but there's a specific etiology that occurs with organophosphate poisonings. The acronym is SLUGM, and this is important because you may see this on National Register, even though it's not in your book. Think about your body has got some invader it wants to get rid of, some poison it wants to get rid of. Remember we're talking about allergic reactions, your body wants to get rid of stuff. If you go through all of these here, salivation All these have to do with fluid pretty much. The body's trying to flush this out. So increased salivation. What's lacrimation? Tears. Urination. Y'all know that one, right? Defecation. You got that one? Or not? Gastrointestinal issues. You become, very movement oriented here. Emesis, what's that? Yeah, it's the bad thing. Emesis is the bad thing. Vomit, yeah. And then meiosis. Huh? What's meiosis? Has to do with the eyes, right? Oh, boy, I got there pretty quickly. So organophosphate poisoning, the only way they're going to fix this is going to be with atropine. And atropine, we carry it on the ambulances, but not enough to fix an organophosphate poisoning. But they'll have plenty at the hospital they'll have plenty for a couple of people exposed, but if you get a whole troop that's exposed, they're going to have to call in a bunch of atropine. And what atropine does is it dries up all of that stuff, which is good. It's my poisoning picture. Okay, we've got one more chapter and it's short. We're going to take a break. All right, 8 o'clock. It's a short break. You can't run across the street and eat or anything. Oh, food.